Hello, let's talk about thalassemias. A thalassemia is a heritable microcytic anemia in which there's a problem making hemoglobin, which is common to all microcytic anemias. Now, there's a problem making hemoglobin due to mutations in either the alpha or the beta globin protein. This creates the anemia and the characteristic hypoxia and pallor due to failure of oxygen delivery to tissues. And it also creates what we call ineffective erythropoiesis due to the accumulation of inclusion bodies within red cell precursors, leading to, in thalassemias, inevitable iron overload. Now, thalassemia is a broad spectrum disease. You can have silent thalassemias, even where you just have the trait, you're just a carrier for it, or you can have very severe thalassemias in which death is possible in childhood, teenage years, and blood transfusion is the treatment of choice for thalassemias to get some red blood cells into a patient's circulation that can deliver oxygen to tissues and will not get phagocytosed by the spleen. Here's hemoglobin, 2 alpha chains in red, 2 beta chains in blue. And then here in green, what's this molecule? That's heme itself. Heme is a protoporphyrin ring synthesized from glycine and succinyl-CoA with a molecule of iron in the middle. And that iron can complex with oxygen. And you've got 4 such heme subunits on the hemoglobin protein for 4 total oxygen that can be stuck onto a hemoglobin at once. So notice you've got 2 alphas and 2 beta globin subunits again. And a problem making the alpha subunit is an alpha thalassemia. A problem making the beta subunit is a beta thalassemia. Now, listen to this, because this is important for understanding some of the nuances or intricacies, the finer details of thalassemias. Whatever chain is unaffected, whatever chain is normal, is going to build up and accumulate inside red blood cells. So if you have an alpha thalassemia, you see these red blood cells here. We've got normal or wild type on the left, means you don't have thalassemia. Then we've got a heterozygote for this alpha thal in the middle. And then on the far right panel, we've got inclusions within a homozygous alpha thalassemic. And what are these inclusion bodies inside these red blood cells? You can see them on electron micrograph here. They're very densely staining. And again, on the far right, that's homozygous. That's a double knockout of the alpha globin gene. And these are very large inclusion bodies. So what are these inclusion bodies? Well, it's beta globin that's going to try to complex with itself to make some hemoglobin. And in fact, in alpha thal, that's called hemoglobin H, when you have 4 beta globins stuck together. Problem is, that's not a very good hemoglobin, so it kind of sticks together, just cruds up the place, and the red blood cell eventually decides, hey, we got to get rid of this guy. He's crowding up the room, you know, he's not doing anything, not pulling weights. You got to fire him, basically. So you put it in a lysosome, and problem is there's so much beta globin that the lysosome just can't get rid of it fast enough. So when there's an inclusion body in a red blood cell and that red blood cell gets to the spleen, splenic macrophages, they're going to pat red blood cells down, you know, and if there's a problem with the red blood cell, well, then the macrophage is going to be like Godfather, you know, in the restaurant, just going to go off to the bathroom, get the gun, go back to the table, red blood cells just sitting there in the spleen doing its red blood cell thing, thinking nothing's wrong. The white blood cell just gone. No more red blood cells. That's what happens in the spleen. That's phagocytosis. And that's going to happen if there's a blood cell laden with inclusion bodies or perhaps if it's opsonized by things like activated C3b or immunoglobulin G, those are other markers that would tell a macrophage in the spleen to take a red blood cell out of circulation. So not only do you have a hemoglobin problem in a thalassemia, you also have a hemolysis problem because of these inclusion bodies. And these inclusion bodies will also be found in red cell precursors. And guess what? Those precursors, if enough trash aggregates inside them, they'll just commit apoptosis. So you've got a hemoglobin deficiency, but stacked on top of that, you've got a slight hemolysis due to splenic sequestration of these circulating red blood cells, and then you've got ineffective erythropoiesis because whenever these inclusion bodies build up inside red blood cell precursors, they die. So a lot going on in this pathology, as you can see. Here's beta thalassemia. Same thing you see here, inclusion bodies and circulating red blood cells. Not a very good sign. So let's break down the thalassemias, and let's start with beta. Beta thalassemia. Again, it's autosomal recessive. It's a standard autosomal disease. It's inherited. And beta thalassemia is very often due to splicing defects. So you know what's a splicing defect? Why do we splice anything? Well, DNA gets converted to mRNA, and then that mRNA has got to reconfigure itself before you make a whole protein out of it. And then you read the mRNA and print a protein out with the help of a ribosome and a tRNA, correct? So that mRNA has exons and introns, and you know what those are, and it's got to take out the introns and connect the exons together. Well, in beta thalassemia, sometimes the mRNA for the beta globin protein just keeps hold of an extra intron. There's a lot of different mutations that can lead to beta thalassemia, and what a lot of them have in common is that the protein, the beta globin protein, misfolds because of this extra intron. So it's unusable. So you just dispose of it, and that too contributes to inclusion bodies. So you've got an unusable beta globin chain. So hemoglobin A is going to drop like a rock. You just can't make hemoglobin A. We go back up to this table on page 3. We see that hemoglobin A is comprised of 2 alphas, 2 beta subunits. So if you cannot make hemoglobin A, well, you got to have a globin of some sort. You got to have some sort of oxygen delivery system. So what do you do if you have a beta thalassemia? Well, you upregulate the synthesis of hemoglobin F, which is 2 alpha globin chains plus 2 gamma globin chains. So please remember that fetal hemoglobin incorporates 2 gamma chains into the tetramer structure. And you're going to diagnose these different hemoglobins on electrophoresis. And that's going to tell you what sort of thalassemia is going down in the blood, because you're going to diagnose a thalassemia when you see an MCV that's low. Let's say it's 70. Okay, that's lower than normal. You've got a microcytic anemia. What's your next step working that up? You want to get an iron study, because iron deficiency anemia, which is usually microcytic, is the most common anemia worldwide. So you order your iron studies, but they come back totally normal. Patient doesn't have an iron problem. It's like, well, now I'm starting to think thalassemia, because that can cause a microcytic anemia that's got nothing to do with iron. So then you want to figure out what type of thalassemia is this, and if it's an adult patient, you know, you're probably going to just send that blood off and get an electrophoresis on it, which is going to separate the different hemoglobins in that blood on the basis of size and charge. And so if there's a lot of fetal hemoglobin in the blood sample, you'll see that as a stripe on the gel or as a spike on the printout. And here's an example of beta thalassemia trait. That means you kind of sort of got a little bit of the disease, because again, there's a spectrum of presentation. There's a lot of hemoglobin A, but there's an elevated fetal hemoglobin in this adult patient, especially in this one on the bottom here. That is looking like something like 15% fetal hemoglobin. So you see that degree of fetal hemoglobin, which again doesn't involve the beta chain, and you're like, oh, patient must have a problem making the beta globin chain. This must be a beta thalassemia. So that's thal minor or thal trait. Here's intermediate thal, in which fetal hemoglobin is the majority of hemoglobin in the patient's blood. And good old normal hemoglobin A, A1, is only accounting for 9% of this patient's hemoglobin. So that's when you say, okay, this is not your run-of-the-mill minor beta thal. This is at least beta thal intermediate. This might be beta thal major. Keep an eye on this patient, genotype them, see what's going on. So when you genotype a patient with beta thalassemia, then you're going to get these results back that give you a combination of plain beta, just B, and that means they have a normal beta globin gene. And then because you have two beta globin genes, well, you could have beta plus, B plus, which means that you've got reduced functionality, but still some functionality. You know, it's as if you're a B plus student. You know, your teachers are looking at you like, oh, okay, this kid has got some potential. He's got reduced potential. You know, he doesn't have full, like he's not fully living out his potential, but he's got a little bit there. He's got a little bit of something going on. So B plus is when you have reduced activity, but a little going on. And then B naught, B0, that means you have absolutely no beta globin, whatever, coming from that one gene. So obviously, if you have B0, B0, if that's your genotype, because you got two beta globin genes, then you have what we call beta thalassemia major, in which you've got nothing but fetal hemoglobin in your blood. And this is actually an electrophoresis taken after blood transfusion, in which they put some hemoglobin A into this patient, and it still was only 20% of his circulating hemoglobin. So if you have beta thalassemia major, you've got just about nothing but hemoglobin F and a little bit of hemoglobin A2 in your blood. And again, that's going to be double knockout, B0, B0. Now, if you got B plus B0, you still got some partial beta globin functionality. So you're going to be making a little bit of hemoglobin A on your own, as in this example, 10% hemoglobin A. So that's the gist of it. It's not that difficult. Before we get back to the text, let's go ahead and take a look at what first aid says about beta thalassemia. So, all right, thalassemias are endemic to certain geographic areas, and beta thalassemia happens to be most prevalent amongst the countries bordering the Mediterranean Sea. So rates of beta thal are highest in Greece and Italy, definitely Italy, Spain, all of those countries lining the Mediterranean. It's also elevated in the Black population, as are most anemias. Sickle cell, G6PD, blood problems are very prevalent in the African American population. And we believe that this is because many blood disorders protect against Plasmodium species, malaria. And the reason why anemias protect against malaria is because in an anemia, your red blood cells got a shorter lifespan. And Plasmodium is an obligate intracellular reproducer inside erythrocytes. It's got to be in a blood cell to divide and reproduce. And so the shorter the red blood cell lives, the less time the parasite has to make a copy of itself. So that's why thalassemia and sickle cell are protective against malaria. And back to first aid. They're giving you minor and major, and you need to understand here, they mention electrophoresis. So that's basically telling you that's going to be incorporated in the question stem somehow to help you make the diagnosis. Again, you're just going to have a microcytic hypochromic anemia, but with normal iron studies. And so iron's probably going to be an answer choice, but it's not going to be the answer if they give you the electrophoresis. And then they want you to understand that patients are going to get a hemochromatosis if they've got a severe thalassemia. They're going to get iron overload. We'll talk about that in a second. First aid also points out something that's not in the SDL is that patients with thalassemias are at a higher risk of parvovirus B19 induced aplastic crisis. And that's because parvovirus B19 gets into red blood cells, I think via the P glycoprotein, and infects erythrocytes. So if you've got a diminished red count to start with, you've got an anemia, well, then that virus is going to be even more lethal. And parvo does like to get into the bone marrow and infect reticulocyte precursor red blood cells, right? So if parvo gets into a bone marrow and causes some damage, well, if you've got thalassemia, your marrow is already a bit impeded because of all those inclusion bodies and the apoptosis from this hemoglobin problem. So a B19 infection is doubly bad in a patient with thalassemia. And then finally, mentioning that beta and beta-thal, really beta-thal, is only going to become symptomatic after 6 months, similar to sickle cell disease, because that's when you stop making fetal hemoglobin. Now, in alpha-thal, you really can't make fetal hemoglobin to start with, or you can't do a good job at it. So that's going to be symptomatic before 6 months in severe cases. And that's really all that first aid has on beta thalassemia. So as you can imagine, the questions are going to be just giving you a couple: beta thal minor, beta thal major, alpha this, alpha that, alpha something else. There's your A through E right there. Maybe they give you an electrophoresis. Maybe they tell you what country the patient's from, and that helps you make the diagnosis. Maybe they ask you for the mechanism of the genetic mutation. And in the case of beta thal, again, it's a splicing defect. So thalassemia is real cool, you know, in that you kind of expect what they're going to ask you. So that's the mechanism of it. Let's read a lot of this section titled Pathophysiology. There's great material in here. The deficit in hemoglobin A synthesis produces underhemoglobinized hypochromic microcytic red cells with subnormal oxygen transport capacity. So why are they small cells? Because they don't have a lot of hemoglobin. So when they're in the marrow, these red cell precursors undergo additional mitoses in an attempt to boost that concentration of hemoglobin intracellularly. So once they get out in the bloodstream, these red cells still have diminished survival. Why? Because of the inclusion bodies that we've looked at earlier. Whatever chain is unaffected, so in the case of beta thalassemia, you get alpha globin inclusion bodies. And again, once these red cells get to the spleen, macrophage is going to pat them down, find some inclusion bodies, take them off to the side, pop, no more red blood cell. That's splenic sequestration. Here it is in the text, bottom of page 5. Unpaired alpha chains precipitate within red cell precursors, forming insoluble inclusions. So now we're not just talking about circulating red cells, but precursor red cells in the bone marrow. Many red cell precursors succumb to membrane damage and undergo apoptosis. That's really important. Those red cells that are released from the marrow also contain inclusions and have membrane damage, leaving them prone to splenic sequestration and extravascular hemolysis. So good little flow chart here. Take a look at that on your own. What I really want you to take out of it, the hub of this chart is the precipitation of excess alpha chains, because you're making too many alpha chains relative to your beta chains. If you understand that, you understand everything about this beta thalassemia. So additional signs and symptoms, and this will apply to alpha thal as well as beta here. You're going to see extramedullary hematopoiesis. What's that mean? That means your secondary organs that can make red blood cells in a pinch are going to do so. So you'll see a degree of hepatosplenomegaly proportionate to the degree of anemia in these thalassemic patients. You'll also see because there's going to be a lot of erythropoietin going around. Okay, understand that. Because there's a lot of erythropoietin, your bone marrow is just going crazy. It's balling out of control, you know. So on the skull, your skull has a lot of bone marrow, and that bone marrow in the skull is going to be pumping out red blood cells like there's no tomorrow under the influence of all this erythropoietin. And so that creates the appearance of what's called the hair on end or the crew cut x-ray. And this is an example of, well, not extramedullary, but just the hematopoiesis that is occurring in a thalassemia. So what's going on here is you've got two layers of cortical bone in the skull, and then you've got kind of a spongy bone sandwich in between. And so this hair-like appearance on the x-ray is caused by cortical bone growing up and red blood cells replicating throughout the trabeculae of bone. Back to the text. That increased erythropoietin that we just mentioned is really important for one more reason. It suppresses hepcidin. So when you see hepcidin, iron is hiding. And that means that hepcidin is going to block gut absorption of iron from the duodenum and the jejunum, and it's also going to lock iron inside macrophages of the bone marrow. Now, if you're in an iron deficit, you're going to have zero hepcidin because you need all the iron that you can get. Well, when you have a thalassemia, you're not in an iron deficit, but you do have a problem making hemoglobin. So the hypoxia mediated by the thalassemia gets to the kidney, and the kidney says, smokes, we need some red blood cells up in here. I'm going to make some erythropoietin. And so that EPO shuts down hepcidin, turns it all the way to zero so that you can get all the iron that you can potentially get from your diet. That's why patients with bad thalassemias, we're talking alpha beta thal major, get inevitably iron overload disease with a big old liver with inclusions and a cardiomyopathy, because EPO is always going to be sky high. So iron absorption is also always going to be proportionately elevated. That's pretty important in the real world, you know, not for taking the test, but for managing these patients, because you shouldn't give them iron. You cannot give them iron. They are never going to need iron supplementation. And just because they have a microcytic anemia, I don't want any of you to leap at that and say, all right, take these iron tablets without getting the iron study first to confirm that they have an iron deficiency. Because if they have a thalassemia, you're just making things worse. So now we discussed clinical presentation of beta thalassemia. You get it by now, spectrum ranging from trait, that's beta thal minor, all the way to beta thal major. And if you have beta thalassemia major, you're going to know that very soon after birth, within the first couple of years of life. Beta thal major is also called Cooley's anemia. Again, it presents most commonly in patients bordering the Mediterranean or who have such a heritage. And so that will be included usually in the first sentence of a question stem. These patients get anemic at a very young age. And so classic textbook symptoms of anemia are going to be pallor of thin-skinned areas and gums especially, and hypoxia, failure to thrive because you need oxygen to grow, and mental lethargy, confusion, trouble breathing, etc. So hepatosplenomegaly, also very, very popular, especially as a kid with a major thal gets a little bit older. Why? Because of that extramedullary hematopoiesis. You need as many red cells as possible, so your liver and spleen start pitching in. Bone deformations are very obvious in patients with a thal major, and that's accounted for by the degree of hematopoiesis taking place in the bones of the skull. So if you're pumping out, you've literally got hyperplasia of the skull, right? So what's hyperplasia? Increase in number of cells. So any other tissue that you could have a hyperplasia in, you know what that looks like. It's like a mole on your arm or something. Well, imagine your skull is the tissue undergoing hyperplasia. That's literally what's happening. That's why you get these deformations of shape. So it's a chipmunk facies. I think that's kind of rude, but at the same time, we're only human. So here's a good chart. Beta thals and alpha thals. Again, notice that beta is the one where you can have, zip it. All right, let me restate that. Beta thalassemias, you got 2 beta globin genes. Alpha thalassemias, you got 4 alpha globin genes. Okay, that's it. That's the difference. So with the beta thalassemias, you could have partial function of a beta globin gene, or you could have no function at all of a beta globin gene. So you've got 2 genes in partial or 0 function or full function in those genes. Alpha thalassemia, there's no partial function of an alpha globin gene. You either got it or you don't. So you either have 3 out of 4 working, you got 4 out of 4, that means you don't have thalassemia. You got 3, you got 2, you got 1, you got 0. Okay, that's alpha thalassemia. So that's that chart. Sorry that I took a little off-road trip there. Now, middle of page 7, talking about secondary hemochromatosis. We brought this up. And again, it's because you have a lot of EPO erythropoietin due to hypoxia that's going to suppress hepcidin. You're going to get a ton of iron. It's going to damage the heart. And remember, the most common cardiomyopathy that you get with iron overload is a dilated cardiomyopathy. You can also see a restrictive cardiomyopathy, and those will have different heart sounds accordingly. Hepatosplenomegaly, often present. Cardiac disease related to progressive iron overload. And again, these patients will get a lot of transfusions, and there's always trace iron floating around any blood products you give to a patient. And so that's adding to their iron overload problem. So they're typically going to be on iron chelating agents orally to prevent or reduce the complications of frequent transfusions. Thalassemia major patients are usually transfusion dependent, and a treatment option that can circumnavigate that is a hematopoietic stem cell transplant. So an allograft or an autograft into the patient's bone marrow. Perhaps they have a sibling who's got a very similar HLA typing. That would be a good choice for a bone marrow transplantation. Or perhaps if the patient was fortunate enough to have been worked up for a thalassemia prenatally, then perhaps you saved some cord blood from the delivery. And so you have some stem cells from the placenta you may be able to culture and then inject into this patient's bone marrow as an autograft. Those are 2 excellent but pricey treatment options that again circumnavigate the need for transfusions. So now we talk about beta thal minor, that's beta thal trait. And this basically means you got no problem at all. You basically don't have a disease. Can you get a little bit anemic? Sure. But you know, it's like, don't we all have days where we feel kind of hypoxic and lethargic, you know? So just because you have beta thal minor doesn't really mean anything for you particularly. It might mean something for your kid. One more time, it's going to be a hypochromic microcytic anemia. You can go take a quick look at that in a picture. Look at these red cells. They're pretty pale. I mean, you don't really see pastel red, but if you did, that's what pastel red looks like right there. That is baby red. I mean, that is practically pink. Those things are very light. They've got a wide, broad area of central pallor. There's not a lot of hemoglobin in those red cells. So now let's talk about the alpha thalassemias. This is a good old autosomal recessive again. There's 4 alpha genes total, and you can have any number of them deleted. So there's a varying degree spectrum of presentation for these alpha thalassemias. Now, if you're missing one out of your 4 alpha globin genes, you're a silent carrier. You have no clue that you are missing 1 alpha globin gene. It's cool. It's cool. If you're missing 2, then you've got what we call alpha thalassemia trait. And this can be cis in the case of the Asian population. Cis, remember, meaning same. And that's when you've got both alpha globins from one parent's locus deleted and both alpha globins from the other parent's locus are conserved. And then you could have a trans alpha thalassemia trait, which is more common in the Black population, in which one alpha globin from both parents has been deleted. And then when you get any less than 2 out of 4 alpha globin genes, if you've got 1 out of 4, that's when you start seeing pretty bad alpha thalassemia disease. We're going to call that hemoglobin H disease. Now, if you have no alpha chains whatsoever, that's incompatible with life. And in a question stem, that's typically going to present as Asian or African parents who have had this 3rd trimester spontaneous abortion, and they both have a history of low hemoglobin, or maybe they give you the patient's both the parents' bloods and they both have low hemoglobin, and you're supposed to infer, okay, this is high drops due to hemoglobin BARTs due to this 0 out of 4 alpha thalassemia. So that's the different alpha thals you could have. Silent carrier, okay, nothing going on there. What's the mechanism? Just plain old deletion of the gene. You just don't have it. No, like partial functioning again. You just don't have however many out of 4 possible alpha globin genes. So what's particularly notable from page 8 here, again, if you see hemoglobin H, understand that what that is it's a tetramer of 4 beta globin units. Because if you have an alpha thalassemia, you got no problem making hemoglobin B. So beta globin is just sitting there, you know, waiting around for an alpha globin to dance with, and there's just no alpha globins at the dance tonight. And so beta globin gets just tired and nodding his head on the wall, and he looks at his beta friends and he's like, all right, yo, let's go smoke some cigarettes in the parking lot. I don't know, whatever high schoolers did back in the red blood cell days, you know. So they just go kick it on their own, and then that's called hemoglobin H. You got 4 beta globins. Problem is that is terrible at carrying oxygen, and it also likes to complex up within cells. And so we find ourselves right back where we started with the inclusion bodies. And guess what's contributing to these inclusion bodies? Hemoglobin H that can't carry oxygen. So it complexes and it builds up in these blood cells, and they get yanked out by the spleen, or they die in the bone marrow. That's what happens in hemoglobin H disease. But in hemoglobin H disease, you have just enough functioning hemoglobin to where it's compatible with life. Versus, again, high drops, which is hemoglobin BARTs, and that particular globin is a tetramer of gamma globin, which is even weaker than beta globin when it comes to oxygen carrying capacity. So that hemoglobin BARTs, that's a tetramer of gamma globin. I mean, it picks up oxygen and it just doesn't let it go. So it's a functionally worthless hemoglobin because it's just sitting there like my oxygen, you know, and it's like the hypoxic muscle sarcomere is like, you want to give that to me? And then the hemoglobin BARTs is just like, my oxygen, you know? So it's not letting go of anything. Same for that hemoglobin H. And so you see these hemoglobins in a question stem or an answer choice, you know they're talking about a tetramer of identical globin chains, be it beta or gamma, and these tetramers don't let go of oxygen, so they just complex together and form inclusion bodies. And that's cytotoxic ultimately. So now we're back to talking about the diagnosis of thalassemias. Again, they're microcytic anemias. Step 1, working working up an anemia is always get your MCV, see what the size on average of these red blood cells is. If it comes back microcytic, you want to get an iron study. That iron study comes back negative, thalassemia is then high on your list. You can get a smear as well, and you might start seeing these target cells or these poikilocytes, which are similar to dacrocytes, teardrop cells. These are non-specific for thalassemia. They let you know something's up with the spleen. Now, after you figure out that a patient has thalassemia, your concern is then to differentiate what's the degree of it. They have trait, they have minor, they have major. You're dealing with a young kid with a very low hemoglobin, probably a thalassemia major. How low is low hemoglobin? Under 5 is pretty low. Under 8, you're getting into where you would expect patient to be symptomatic. 10 or so, that's like trait, okay? Patient probably doesn't even know they have anything. Again, you are always getting that iron study. And in thalassemia, ferritin's normal because that reflects total iron stores in the body. And transferrin is normal because ferritin's normal, and transferrin is going to do what ferritin does, or the opposite rather. Perhaps patient's got a hemolytic anemia because we discussed inclusion bodies leading to splenic sequestration of red blood cells, and then they take them off to the side and they take them out. And so when that happens, you spill a little bit of bilirubin into the blood. So you get an indirect hyperbilirubinemia. Is that unconjugated or conjugated bilirubin? That's unconjugated bilirubin, right? So once your bilirubin hits, I don't know, like a 1.5 or 2 above normal, you're going to start seeing jaundice in the sclera of the eyes. And so jaundice is the classic sign of hemolysis. Table 2, diagnostic criteria of beta-thalassemia syndromes. What they're telling you with this is you are going to get a gel electrophoresis in a question, and it's going to help you answer the question. So understand these findings on gel electrophoresis. All right. Good news is they're going to label it. They're not just going to, take out the names, all the hemoglobins, and expect you to know which one travels the farthest. No, they're going to say this one is hemoglobin A. This one is hemoglobin F. This one is hemoglobin A2. It's going to be, they're putting it on a T for you because that hemoglobin F, there's no beta chain in it, right? So if you have a problem making beta chains, you know that there's a beta chain in plain old hemoglobin A. So if there's no hemoglobin A whatsoever, you have to be dealing with beta thalassemia major. There's really no other choice. Maybe some, like random thalassemia that's going to be tested on your second level boards whenever you're a hemonc resident. But for step 1 purposes, thalassemia major is the only thing it can be if there's no hemoglobin A. Now, thalassemia trait, what's that look like? Hemoglobin, fetal hemoglobin's up a little bit, just a little bit. Hemoglobin A2, that's 2 alphas, 2 deltas, that's up a little bit. Hemoglobin A is down a little bit. So what's our magic number for hemoglobin A? It's going to be 95 to 97% is what standard adult hemoglobin typically is in the bloodstream. Any lower than that, and you got a beta thalassemia trait or something. Again, reference ranges, hemoglobin A, 95 to 98%. There we go. That's important. So then we talk about alpha thalassemia a little bit. If you have an alpha thalassemia, let's go with green here. Here's hemoglobin H disease, which again is going to be when you have 1 out of 4 functioning alpha globin genes. You're going to get hemoglobin H, which is a tetramer of beta globin, and that's going to show up as its own little independent stripe on electrophoresis. So if they tell you that's hemoglobin H, you can't mistake it for anything else. And then hemoglobin Barts, that's when you don't have any alpha globin at all. You don't really ever electrophoresis that because the baby dies in utero. Talking a little bit about hemoglobin H disease, same exact presentation. Very similar to beta thalassemia major. Again, this is a significant anemia. You're missing 3 out of 4 alpha chains. So what's hemoglobin H? One more time, beta chain tetramers. They want you to know that. You're going to see hemoglobin H as precipitates inside blood cells when you stain with Cresol blue. And it looks like the Epcot ball at Disney. There we go. Now, wrapping it up, talking about treatment, chronic transfusions for patients with severe alpha or beta thalassemias. And with those transfusions comes an increased risk of skin side infections or transmissible infections such as Hep C, HIV. Iron overload is also inevitable in patients with severe thalassemias owing to increased erythropoietin because the anemia just doesn't go away. So the EPO stays high. So hepcidin stays very, very suppressed. You have no hepcidin. So you're pulling in all the iron that you can get from the gut. Again, stem cell transplantation, bone marrow transplantation can be totally curative, but it's a steep price. Untreated severe alpha thalassemia, again, that's hemoglobin Barts, causes intrauterine death. Untreated beta thalassemia major is fatal by the age of 5 years for the majority of patients. If you have treated beta thalassemia major, you can live about into the 3rd or 4th decade of life tops. Very bad condition. Thalassemia intermedia, that's going to be maybe you have 2 alpha chains out of 4. Maybe you have half of your beta chains functioning. Those have a wide range. Patient might need transfusion, patient might not. And then finally, whether it's alpha or beta, if it's minor, if you're just a carrier, you really are never going to have much symptoms at all come out of this. You will not need transfusion. So that's thalassemia. I'm going to go back and point out one more thing here. We're realizing that we can treat thalassemias with rapamycin. So what is rapamycin? It's an mTOR pathway inhibitor. What's the mTOR pathway? Well, the mTOR pathway activates whenever you need to synthesize some proteins, okay? So I watched a Peter Attia podcast. He was talking about how whenever you're eating proteins, dietary proteins, leucine, the branched chain amino acid, is actually the signal to cells of the body to upregulate the mTOR pathway, saying, hey, you've got some amino acids from the blood. How about you use them to synthesize proteins? And so that's generally what mTOR does. It's the on switch for protein synthesis. Now, rapamycin shuts that off. So it puts cells into a state of autophagy. So when you're not making proteins, you should be consuming them, cutting them down. And that's the same thing that happens to all the cells in your body under the fasting signal, the glucagon signal. You haven't eaten for 36 hours. Okay, there's zero mTOR activity. You're not building anything. You were thoroughly catabolic. So rapamycin kind of amplifies the catabolic state and gets cells breaking down proteins instead of building them. So can you imagine that for a thalassemia, whether it's alpha or beta, because you have this problem of making too much of the other globin protein, that anything that stops protein synthesis is going to slow down the rate at which you create these proteins that just get stuck in inclusion bodies and aggregate inside your blood cells. So that's a great thing for a thalassemic, because that means there's going to be less splenic sequestration of these inclusion body blood cells. There's going to be less apoptosis in the bone marrow, because there's going to be less synthesis of these globin proteins. So rapamycin is being explored as a treatment alongside constant transfusions for thalassemia major. That's all I wanted to share about that. Man, this is just a beautiful picture, though. Hemoglobin is a really, really pretty protein. Thanks a lot. See you next time.